Hi, this is Dr. Bob Dannenhoffer. It's September the 4th, and we're doing another one of our Facebook Live events tonight. So thank you for joining us. It is the day before a 3-day weekend, so we don't have a zillion viewers tonight. I will certainly understand. Again, as I usually do, wear a new mask each time. This one is one from Under Armour that's said to be great for exercise. It's pretty nice, but they're really expensive these days. This one's about $30, so I'm not sure I would do that all the time, but it's a pretty nice mask. I'm going to take it down for those people who like to lip read. I'm sufficiently socially distanced from my partners here, so that should be good. Again, this is your time to ask questions. With not many people here tonight, you get a better chance to ask questions tonight, so let's go. So, as we typically do, we start from the top. Still a very active pandemic in the world. 26.6 million cases and 875,000 deaths. We're continuing to add cases, about 300,000 cases per day, and about 6,000 deaths a day. That is a lot of cases, a lot of deaths. And we're continuing to be very active in the US, Brazil, and India, and then really everywhere in Central and South America, except for maybe Colombia and Uruguay. But very, very active in the Western Hemisphere. And that is a problem because there's so much movement in the Western Hemisphere and so much movement through the US that it's going to take a long time to bring this down to very low levels. In the US, we're at 6.3 million cases and 191,000 deaths. Both the clear to the death rate and the case rate are coming down, but we're still adding about 1,000 deaths a day. And so we're at 191,000 deaths very clearly by the 15th of September. We're going to be at around 200,000 deaths. Still very active in California, Texas, and Florida. We've been saying this for 4 weeks now, but it's still very active with thousands of cases a day. Interestingly, Arizona really took this to heart. Arizona really clamped down, and they've been able to really bring their cases down. We're starting to see new clusters coming out. West Virginia, Georgia, North Dakota, South Dakota, Iowa, and places where there are college campuses really seeing a lot of cases. So University of Alabama had 1,000 cases on one campus. Oregon is very quiet. We're about 27,000 cases, 460 deaths. We're adding 200 to 300 cases a day, which is way too many. But our death rate is fairly stable at about 5 per day. Douglas County has been far and away the best place to be. We're still at 180 cases, no new cases today, and really only 3 new cases over the last week. Very low. We're still at 3, we're just still at 3 deaths. With so few cases, it's hard for me to tell you much about new cases, but over the last 3 weeks, our cases have been, again, people traveling, family gatherings, and then coming back to work. So on this weekend, when everybody wants to travel, be very, very careful about travel and then coming back to work next Tuesday. So let's see if we've got some questions here. So what should you do if you think someone has COVID and wants to get tested or doesn't want to get tested?
Doesn't want to get tested.
Okay. So they have COVID and they don't want to get tested. And there's some people who don't want to get tested either because they don't want the swab up their nose or they feel they're going to get negatively impacted if they test positive. They should stay home for 2 weeks. Even if you had it, if you stayed home for 2 weeks, you would no longer be contagious. So stay home for 2 weeks or work at home for 2 weeks. Okay, so we've got a bunch of things that came out this way. One is that very nice study from China that showed airborne spread on a bus. So typically we think when we're right next to somebody and talking that most of the transmission is by droplets. But what this showed is that on a longer bus trip that this disease did seem to be aerosolized and people throughout the bus, even who were way more than 6 feet away from the person, got it. This goes along with the report that they had on a train, a high-speed train. And again, it looks like if you're in a packed little space for a long period of time, that this can become aerosolized. So, again, avoid buses and trains. A couple other things that came out this week. There was this wedding in Maine. So an indoor wedding, and then it spread to other people at the wedding, and then spread to a prison, and spread to a long-term care facility. And they are now up to 143 cases from this one person at a wedding. In Oregon, there was one beach party that went from one, and they said they now have 300 cases. So while in some cases this doesn't spread at all, so we have some people don't spread it to their spouses, other cases it spreads like crazy. And since you can't tell which is which, we're asking to be very careful about big gatherings. All right. So is the face shield as effective as a mask? Somebody asks. I'm moving the camera here. So is a face shield as effective as a mask? Well, it depends upon what you're looking for, right? So if you're looking for protecting your eyes against flying metal, which is typically where the face shields were designed to do, they're much more effective than a mask, not surprisingly. But in terms of preventing you from getting disease or preventing others from getting disease, it's unclear whether it's better or worse than a mask. There have not been a lot of good studies. There's one guy from the University of Iowa that has done quite a bit of studies. He shows it's really quite effective, although since they have not done a lot of studies out there, the CDC does not recommend a face shield alone. Now, I will tell you that there's some people who cannot wear a face mask because of, for whatever reason, they find it too uncomfortable, they have had a previous smothering attempt, or they just hate the way the mask works, in which case a face shield is so much better than nothing. So if you have a choice of a face shield or face mask or nothing, clearly a face mask is better, and if nothing and a face shield is clearly better than nothing. So primary would be to use a face covering, next would be to use a face shield, and please, please, please wear something. Okay, other things that came out this week, there was a study that came out from the University of Chicago that looked at vitamin D and found that people who had low levels of vitamin D were more likely to get COVID and more likely to do badly than people who had higher levels of vitamin D. Hard to know about this. There have been a zillion studies over the years looking at vitamin D, and typically low levels of vitamin D are associated with worse outcomes. However, if you now give people vitamin D, they don't seem to do any better. So it may be that vitamin D is low in people who are otherwise sick, and that's not surprising because vitamin D is naturally made in your skin when you're outside running around. So if you go for a 10-mile run every day and get a lot of sunshine, your vitamin D level is pretty high. If you work out in the garden for 2 or 3 hours a day, you're going to have a high vitamin D level. If you're so sickly that you're sitting in just watching TV, you're going to have a lower vitamin D level. So the difference in the disease may be related to the vitamin D levels, or it could be related to the pre-existing things that gave you the low vitamin D levels. In any case, taking a vitamin with vitamin D in it is a good thing. Drinking milk with vitamin D in it is a good thing, so I certainly encourage that. Okay, so a couple of other things. One of the most disturbing things of the week is that the NCAA has been very carefully looking at the heart of patients who've had COVID-19 and now want to play college sports. So no matter how serious you are, if you've had COVID, the NCAA is requiring a cardiac MRI on these people. And a third of the students who had COVID, regardless of how sick they were or not sick they were, have significant inflammation in their heart. This is really, really, really worrisome. That inflammation is called myocarditis. Myocarditis is a bad disease. It can lead to later heart failure, it can lead to arrhythmias. We don't know what this is going to lead to, but it is really worrisome that these young, healthy guys, you have to be really young and healthy to play college sports. And so that a third of these people have abnormal cardiac MRIs. That is very worrisome. Now, it's possible that this is going to resolve over the next few months. Their heart function is going to be great, but that's going to be something we have to really carefully look at. So Stephen says, can the virus be found in fecal samples? Is a stool sample a way to test for the virus? Well, there is a test for looking at stool samples. It has not been granted emergency use authorization by the FDA, so it really can't be used in clinical practice. But we do know that if you sample the sewage systems, you can get an idea of whether there's COVID circulating in the community. And in fact, one of the colleges did this from each of the dorms, and they found one dorm where there was a lot of RNA in the effluent from that dorm, and they found that there were a bunch of people who had it. So that's actually reassuring. Oregon is doing that. They're checking different places to look at the amount of coronavirus RNA in effluent. I think at this point it's mostly on a research basis, but it's very interesting. Now, could you do a stool sample to make the diagnosis of COVID? It is really hard to know, and again, until those tests get approved and studied, we don't know. We actually had one patient who thought that they had it and did have a positive stool test, but at that time, positive stool tests were not accepted, so that person didn't get counted. So while people have been worried about overcount, maybe us overcounting because of presumptive tests, if anything, I think we're undercounting because we're not counting positive antibody tests, we're not counting positive stool sample tests, and so you probably miss some on both ways. If anything, I think we're probably undercounting. Okay, a couple of other things. One, you remember I did this Doppelganger analysis where I looked at these 4 counties. We put up a second video called Doppelganger 2 that answered many of the questions. So some of the questions were things like, well, maybe these areas are not exactly the same because there's a difference in demographics, and indeed there was. We found that Douglas County had the oldest residents, Valdosta had the most people of color, Rapid City had the most Native Americans, and Twin Falls had the most Hispanics. But overall, since older age is the strongest predictor, Douglas County should have done worse, and we did better. Second thing we looked at, somebody said, well, what about seasonal workers? So we looked at the number of seasonal workers in each of these areas. Douglas County had over 900. None of the other areas had over 500. So again, it's unlikely that the number of seasonal workers would have accounted for the differences. And then people talked about stuff like, the number of through traffic. And so each of these areas is on an interstate, and that's one of the reasons I picked them. Actually, it turns out that I-5 is the busiest of the 4 interstates. So again, that didn't explain our better experience. I think what explained our better experience is good luck, and there's no question that good luck has to do it. The fact that the counties around us don't have a lot of disease, because if you're in an area where the counties around you have a lot of disease, you're likely to have more disease. And I think we took a stronger approach than those other areas, so we'll take a look and see. I've done a similar doppelganger kind of analysis for Sweden, Norway, and Finland. So if you look at Scandinavia, there's 3 countries in Scandinavia, and Sweden's in the middle, and Norway's to the west, and Finland's to the east, and they took slightly different approaches. So Norway and Finland took a stricter approach. Sweden took a less strict approach. Norway has about 5 million people. Finland has about 5 million people. Sweden in the middle has about 10 million people. And when you look at it, Norway and Finland each had 200 or 300 deaths. Sweden had 5,800 deaths. And when you look at the unemployment in the 3 areas is virtually the same. So it looks like, again, there's a little less economic disruption in Sweden, but a lot more deaths. So it looks like you can be more restrictive and have fewer deaths, and you might have a little bit more unemployment. So again, when we looked at now all of the counties in the U.S., that also appeared to be true. So Bruce says, does getting the flu shot have a lot of the benefits considering all we're doing to avoid COVID? And so the hope is that we're not going to have very much flu this year because all we're doing to avoid COVID. But getting the flu this year is going to make it so complicated to figure out, do you have the flu, do you have COVID, or do you have both? So that's why we're very, very, very strongly recommending that people get a flu shot. All right, well, one of the other things that we looked at is, people have asked us for our demographics here, so I'm going to see if you can see this well. So of what ages? We have enough cases now that I think you can look at this. This is good.
You can bring it closer.
Bring it closer.
Yep, there you go.
How's that look? Okay, so this looks at the age distribution. As you can see, it's pretty even
Our average age was 47, but we had kids down to as low as 6 and people to the age of 80, pretty evenly distributed throughout. Now, this is not the age distribution in the county. The age distribution in the county is much flatter, but again, not surprising that people in their 20s, 30s, 40s, and 50s would get the most disease, because presumably they have the most contacts. We also look to see about chronic diseases in here. You probably can't see this all the way, but one of the things that I keep hearing is, well, all these people have underlying conditions, so maybe this isn't such a big worry. So I actually looked at the statistics, and the statistics show that by the time you get to be age 65, 86% of us have one or more underlying conditions of the big ones: cancer, heart disease, lung disease, asthma. And then when you put in the other kinds of underlying conditions like obesity, smoking, and neurologic disease, over 90% of people over 65 have an underlying condition. So it's not at all the least bit surprising that most of the people who die have some underlying conditions. But, this disease is also killing younger people. So when I try and think of, in my mind, the healthiest people out there, the fittest people out there, the people have to be in pretty good shape to do the jobs they're doing, I think of firefighters, I think of policemen, I think of active duty military people. So I looked over 2020 to see how this was affecting the different areas. So among police officers this year, I was surprised that the leading cause of death among active duty police officers is COVID. So it's like 100 police officers died of COVID, only 31 died of homicides. So the website is called Officer Down, and it really shows that COVID is going to be the leading cause of death among police officers. I looked at firefighters. 40 or so firefighters as of this summer died of COVID. That's probably going to be more than all of the firefighters who died of fire-related or accidental causes. I then looked at the U.S. military. So the U.S. military has a lot of accidents. There's young guys doing kind of foolish things. And so accidents and suicides are the two leading causes of death in the military. But the third is going to be COVID. So after accidents, after suicide, it's going to be COVID, and it's going to be far greater than the number of soldiers killed in enemy action. So, yes, this does kill a lot of people in nursing homes. Yes, it does kill a lot of old people, but it also kills a lot of young people. The 3 deaths of the people in Douglas County, these people were very active. They were traveling, they were doing things. These were not people living their last minutes in a nursing home. These were people expecting to live another 5, 10, 15, 20 years, and yet they died because of COVID. So, although it's not, as you get younger, or as you are younger, and as you have less underlying conditions, your risk of dying is less. But I don't think you could tell the 88 active duty people. I don't think you could tell the 101 police officers. I don't think you could tell the 43 firefighters that, look, you have no chance of dying. You do. And even when I looked in kids, there were 88 deaths among kids. That's relatively low, but the number of total deaths among kids is relatively low. I looked, for example, at the number of kids who died of leukemia, which is the most common cancer in kids, and about as many kids are going to die of COVID this year as are going to die of leukemia. So it's bad. Let's go ahead and keep it down. Douglas County is doing so well. Again, over the last 4 weeks, I think we've had less than 30 or 40 cases over the last 4 weeks. We are at a stage now where we can keep this level low and the state positivity rate continues low. We can start to open all of schools within the next week or so. So I'm just pleading with people to keep up the good work. Okay, a couple more questions. Yeah, so when there's a vaccine available, would you recommend everyone get it or just certain groups? What about babies? I don't know what the recommendation is going to be. I was on a long call today where we talked about the vaccine. They haven't tested it in babies, so it's likely not going to go ahead and be approved for babies. I hope they do a good, rigorous review of it. If they do this rigorous review and say it's good to go, I think people should get it. They will start off by telling who should get it first. Now, it turns out that vaccines generally don't work well in the very elderly. They typically work best in young adults. But since young adults don't seem to get very sick from this disease, that doesn't seem the group that you would give it to. So I'm not sure how it's going to work. Maybe healthcare workers first, and maybe people in nursing homes first. I'm not sure how it's going to be. So Linda said, I had a flu shot earlier this week and it was the most pain-free ever. Has the technology changed? No, flu shots have changed a little bit over the years, but it must have been just somebody who gave it to you. Well, no big changes here. So if you were doing a family gathering and everyone did a COVID test prior to the event, how many days should it be done? Well, ideally, everybody would quarantine for 14 days. That would be far and away the safest way to do it. So if people were just going to get a COVID test and not do any quarantining, there's no recommendations for that. So, you know, obviously you want to get the results back before you had the event. And the only tests that are approved actually for asymptomatic screening are the PCR tests that take 2 or 3 days to get back. So maybe 3 days before the event with a PCR test. Yeah, so how many different strains have been identified? Is there a variation in effectiveness between strains? There are at least 100 different genetic mutations here. Most are very, very minor and don't really make a big difference. So what I tell people is that when any virus reproduces, it can reproduce absolutely perfectly, or it can reproduce with a little change. And most times the little changes are kind of nonsense little changes, and it really doesn't make a big difference. So probably the best analogy I had was if you took the work of a master, something from Van Gogh or something like that, and then had somebody repaint it and make a copy of it, that copy is not going to look exactly the same as Van Gogh. The ear may be a little different, the left brow may be a little different or whatever, but if you look at it, you clearly understand that this was a Van Gogh. Occasionally, there'll be a change, which is a significant change. Instead of 2 people in the background, there are 3 people in the background. And similarly with viruses, occasionally there'll be a change, which is an important change. We think one of the most important changes is on the 614th site. It changed one molecule, and as it changed that one molecule, it changed the structure of the spike protein. So the spike protein is the protein we think that this virus uses to get inside of cells. In the old kind of this, the spike protein frequently broke off, and when the spike protein broke off, it was then not available to get into the cell. What we are seeing is with this new mutation, the spike protein is much stiffer, and by being much stiffer, it doesn't break off as much, and we think may have increased its infectiousness. So infectiousness means how many other people will get it from you, and that's why actually when you look at the RT in this is the reproductive number at any section time, it's still pretty high, and that's why we think you could spread it, for example, to 142 people in a few generations from a wedding, or hundreds of people on a boat. We don't think it's changed lethality at all, but we do think it's changed infectiousness. There are a bunch of other little changes that probably haven't made much difference. Providence had did this lovely study where they looked at all of the viruses they got, all the genetic sequences they got, and where they came from. And you can see these trees that diverge and diverge and diverge again. So again, if you think of a tree, starts off with one trunk, but by the time you get to 3 or 4 generations out, there's lots of different branches. So is the flu shot ready? It is ready. There are some places that already have it at drugstores. It's a little peculiar in the United States that drugstores get it before doctors' offices and hospitals, but that's the way it is. And so that there are some there. We're expecting to get our flu vaccine sometime in the next few weeks. So again, the best time to get it, October, is 2 months before the flu season. Never know when the flu season is going to be, but October, November, and early December are key times to get it. I hope to have some incredibly good news in the next 2 weeks about some great looking flu clinics that we're going to be doing in the next few months. Okay, almost done here. If you have questions, let us go. I know it is a Friday before a holiday, and I'm not too upset that they're there. A couple of new things. One is, it is looking like saliva is going to be a great place to sample from. So early on, the saliva studies were a little confusing because there was not a particularly great way to collect saliva. They've standardized saliva collection, and now with a standardized saliva collection kit, it looks like saliva is going to be as good as the nose and as good as the nasopharynx. Oh, won't that be great? I would love not to have to stick a thing down somebody's nose ever again. I probably have done 300. So I would be happy never to do that again. And if you could collect it with spit, that would be fine. You know, we were very concerned that when schools open, having to collect those deep nasopharyngeal swabs is going to be really hard because you might be able to hold down a kid and do it once, but boy, the next week is going to be really hard. However, getting kids in school to spit, I have no doubt that kids will comply with that demand. Can you fill this cup with spit? I'll bet you they'll overflow that. So I'm really, really pleased that saliva is looking so good. The other advantage of saliva is that it's more easily pooled. So the way a pooled specimen works is, let's say there's only, you're only expecting one person in 100 to be positive, kind of like we have in Douglas County. Way to do it is you could test all 100 people. That would be good, but it takes 100 tests. And each of those tests take a little bit of time to do. Now, what you could also do is you could take those 100 samples and what we call pool them into pools of 20. So you do 5 tests of 20 with a likelihood of only 1 in 100 being positive. Only one of those pools is going to be positive. The other 4 you can say are totally negative. You're good to go. The one pool that's positive, then you test them all. So in that case, you would do 25 tests rather than 100 tests. Save on testing materials, save on time. It could be a much faster way to get negative results, right? Because those negative results from the people who spit the first time and the pool was negative, you could do it. So pool testing is getting there. Yeah, so is there a site where we can track flu infections in Douglas County? Probably not easily. So even COVID is hard to track because and there's not very many infections, and we have a system where we get all the positives and all the negatives. Flu is not a reportable disease, and so we do not know the number of positives and negatives. Now, for the last 3 years, we at DPHN talk with people at Mercy every day, and we say, hey, how many flus did you get? And so we use how many come into the emergency room. Now, obviously, that misses what comes into doctors' offices, what comes into urgent cares and whatever else, but gives us sort of a view. So if Mercy says, geez, we haven't had any flu in this last week, and they haven't, then there's very little flu going around. If they say we had 80 in this last week, there's a lot of flu going around. So we can get sort of a view, a comparative view of what's going on, but we're probably not going to get the totally accurate numbers. And the reason for that is the flu test is there are these little tests, and there's no one particular way to report them. This is one of our concerns when we start getting easier COVID tests, is that people may tell us about positives, but we may not hear about the negatives. So, yeah, actually, I think this year in Douglas County, we may actually publish the number of positive flu tests at a certain number of clinics if they'll work with us on those. So Dale Ann says, Merry Christmas on that saliva test. I hope it hits in time. And I do too. You know, every year I ask for something for Christmas. Sometimes it's that one of my patients gets better and I only share that with my family. Sometimes for Christmas I ask for x-ray vision. I always thought as a pediatrician it would be great to have x-ray vision. So because I think I broke my arm, I could just look with x-ray vision and say, no, it looks fine. So, but I've never gotten x-ray vision, but maybe this year I will get that saliva test again. I know I've been talking about this for months, and it really does appear that other people have heard me, probably not, and have made these tests, but it looks like we might get these tests. Becton Dickinson has come up with these tests. The federal government bought 150 million of them. Still unclear what they're going to do with them, but saliva tests, if they really worked, would be great. The other thing I want for my birthday, which is February, is a good vaccine. I think looking for a vaccine in October, November is a bit early. Again, remember when we do these vaccines, we do phase 1 studies, which were done back in the late spring and early summer, where you look at just a few people and you look to be sure there are no really bad side effects and and that they develop antibodies. Phase 2, more people, you're looking again for safety and development of antibodies. And then phase 3, 30,000 people on each side, some who get the placebo, some who get the virus, some who get the vaccine. And what you're looking for is you're looking for rare side effects. So if 1 in 1,000 person develops a paralysis, or 1 in 1,000 persons develops something, you want to know about it, and that's why you need 30,000 in each group to see if there's going to be a difference in that. The other thing you want to find is you want to find efficacy, and the efficacy would be that in the 30,000 people who got the vaccine, none got the disease, and in the 30,000 people who got the placebo, say 300 got the disease. If that were the case, that would be 100% effectiveness of the vaccine with no side effects, and that would be great. Typically, these things take a long time. I really, really hope we don't rush on this, because the concern is if we rush on this and then 2 weeks after it's out, they say, ooh, by the way, we looked at the data and there is this rare complication. That's going to cause so much trouble. So the hope is that they do a very careful analysis before it's approved, and then when it gets approved, everybody gets it. Okay, well that's all I got for tonight. It is again Friday, September the 4th. We're going to do this again on Tuesday. In the next 2 weeks, we're going to go ahead and do a town hall. And this town hall is going to be a little bit different. This is basically me talking and you writing questions. We're going to do a way where people can actually ask questions, and not just about the medical side of COVID, but they can ask about county response and other kind of things along the way. So we're planning that along the way. If you're interested in doing that, let us know on the chat, and especially we're looking for curators. What happens here is that we have our staff here who curates questions, but we're looking for other non-staff people to look at the questions that come in so that we get a broad range of good questions. So if you're interested in helping us on this town hall, put your name in there and we'll get you going. Again, this is Dr. Bob Dannenhoffer, Public Health Officer in Douglas County. We'll do this again Tuesday night. Thank you.